Globally, the population aged 65 and over is growing faster than all other age groups. According to data from World Population Prospects, by 2050, 1 in 6 people in the world will be over the age 65. 2021, seniors 60 years and older outnumbered children under 5. By 2050, 80% of seniors will live in low and middle income countries. Adapting health and social systems to this demographic shift is a major challenge globally. We believe it is everyone's responsibility to provide solutions for the social determinants of health. We are motivated by a deep sense that these issues can have immense consequences on individuals, families, communities, and society as a whole. We're mission-driven. Join us on the Boomer Living broadcast for episodes of full information, inspiration, and advice for seniors. Our expert panelists will discuss topics like senior healthcare, dementia, caregiving, technology for seniors, and affordable senior living options. This podcast is your guide. And here is your host, Han Brown.
Hi, I'm Han Brown, the host of the Boomer Living broadcast. On the show, industry leaders share information. Hi, I'm Han Brown, the host of the Boomer Living broadcast. On the show, industry leaders share information, inspiration, and advice for those who care for seniors. Our expert panelists discuss senior healthcare, dementia, caregiving, and technology for seniors, affordable senior living options, and financial security, all of which address the social determinants of health. So thank you so much for participating in today's conversation. Check out CareString, our recently launched platform where we match seniors with caregivers and guide businesses and their employees through the caregiving journey. So check out CareString. Now, for those in the audience, we'd love to hear from you. We're all learning together as we navigate in the later part of life, taking care of our elderly relatives or as a professional. So please comment and ask questions. And thank you so much for tuning in, and I look forward to your participating. Today's topic is COVID, aging population, and social determinants of health. As a society, we're living longer due to better living and healthcare. While reaching old age is something to be thankful for, there are several challenges facing seniors that we should all be aware of. We don't realize how much we can help our aging population until we start to age or see a loved one struggle. Well, here are just a few concerns that seniors face as we live longer. Memory loss, dementia, Alzheimer's disease, Parkinson's disease, inability to drive or travel independently, hearing loss, vision problems, including blindness, falls resulting to injuries, chronic pains, arthritis, depression, loneliness, social isolation, financial insecurity, scams, and abuse. Many are the social determinants of health. It's common for seniors to develop chronic disease as they age, but not all seniors have equal access to care. So during the pandemic, there is a growing gap in disparity in care, which has exacerbated under stress, and it's more common in medically underserved seniors than the general population. The U.S. Department of Health and Human Services promotes sound scientific advances in medicine, public health, and social services to improve the health and well-being of all Americans, especially seniors and the disabled. Well, joining me today in conversation is Dr. Leith States, Chief Medical Officer in the Health and Human Services, Office of the Assistant Secretary of Health. He has spent his career advocating for vulnerable populations and advancing social justice. Dr. States believes that everyone deserves grace, everyone deserves a second chance, and everyone is worthy of love no matter what they've done or had done to them. So we all need truth to hold on to as we make sense of our life experiences. So Dr. Leith, welcome to the show.
Thank you, Han. I really appreciate that introduction and pulling a more meaningful bio that reflects some of my personal thoughts. It's such a pleasure to be with you and to be with your listeners. As a personal note of thanks to them, please add questions. I love to have a dialogue and have my boundaries expanded when I'm in these settings. So more than happy to be challenged on my thoughts, my comments. This is how we all learn. So pleasure to be here.
Thank you. Thank you so much. Well, today we're going to discuss COVID's impact on seniors, aging population, and the social determinants of health. So I guess, why don't we get started by why is there so much debate about vaccines despite the majority of scientists agreeing that they're safe?
So that is obviously a loaded question, and I've wrestled with this. In my background as a preventive medicine physician, I have I guess a higher level of attachment to population level care, to the historic victories of public health, because that's what my specialty is founded upon. And I, by function of that, I guess, starting point, have to look at history as my great teacher for why we are where we are with regards to vaccine hesitancy, mistrust, distrust. And I think, even if we go back to the early days of vaccination, and I mean Lady Montagu and Edward Jenner, there were anti-vaccine perspectives and thoughts and concerns expressed at that time, for a variety of reasons, right? It was a challenge to thoughts about the deity, about what their relation was to God, going into God's place. There are considerations on the cultural bounds of, well, you're not from where I'm from. You don't think like I think, so therefore I will not subscribe to your method of medicine, right? And I'm extrapolating a bit because what I'm referring to in history is, prior observations from other cultures in Southeast and Southwest Asia that informed European thoughts on vaccination. And now I see that with some of the somewhat polarized dimensions of thoughts around autonomy, and where public health authorities start and end, and then how that rolls into the political spectrum of leanings and spectrums, I guess, the ends of the spectrums that we've seen fuel some of the increased debate. So I think it's a matter of history. I think it's a matter of our current state with social media, with the capacity to be informed and challenged only in our point of view and our thoughts. I do believe that there are valid points across all ends of the spectrum. There was a time when, we were in charge of our bodies. If I wanted a medicine, I would take that medicine. There are regulatory agencies in place now. There are state regulations. There are local mandates. There are ties on the pharma and vaccine makers that allow for, permit, and I would say drive the notion that there's in some instances a asymmetry of power, where folks could perceive that, they don't have my best interest at heart. So I fully understand where folks may be coming from that standpoint. And I think that is one part of the argument. The other piece, and I'll be brief on this one because I think this is probably a more easy to digest, or at least wrap our minds around, is distrust, mistrust from the standpoint of longstanding wrongs in communities, racial, ethnic minorities, and persons with disabilities and otherwise disadvantaged, underrepresented populations. I think that's much more well documented, and I think it puts it shifts the way we as medicine and public health providers have attempted to bridge that gap to bring people in the past. It's not enough to just stop and say, we have this, come take it. And if you don't come get the vaccine, it's your fault. we need to acknowledge where the barriers are and what we can do to meet folks, 50-50 or maybe even a 60-40. And I think there's been a course correction that's helped blunt some of that. But, once you start down a course with a response effort, it's really hard to turn that back, especially from a public health standpoint. So that's a really long answer to a really complex question. Hopefully that generates some good thought from your listeners.
Yeah, very complex question. I understand. So, will there be an increased need for booster vaccines in the elderly population due to COVID?
Yeah,
Further booster vaccines?
yeah. So I think we've seen strong data that is supportive of boosters in certain settings, certain populations. More so for folks that are immune compromised, have existing comorbidities. So from that standpoint, there are blanket recommendations where it will be helpful to have boosters utilized by aging populations. And then as a subset, I think there's an even greater need in communities that have immune compromised state and also have comorbid conditions like diabetes or untreated or poorly managed cardiovascular disease, existing respiratory diseases, maybe COPD, emphysema. So a shorter answer, but the take home is yes, there will be a need.
So, do you think the elderly are being disproportionately impacted by COVID?
Again, this is excellent. A really good question. I like this one because it is I think, a good picture of how COVID has been a great revealer. And by that, I mean, for most issues that regard health and public health, the general rule is children and the elderly are going to be more heavily impacted than other populations. For one, at the early spectrum of life, kiddos don't have a voice. They aren't well represented, and there's not a lot of money in doing research and developing solutions for children. And the problem is they're not little adults. They have their own physiology, their own makeup. There are unique risk factors that get forgotten in their population very often. And in the aging population, I think it's similar in that we've extended life and allowed for the bright, shiny developments in medicine, in therapeutics, in device development, procedure development, in our understanding of basic science and clinical research to help extend life, right? And on the back end of that has not been the infrastructure built in to accept that increasing population. So I do think that there's been a widened gap, and this is demonstrated in some quality and increasing research that there are widening gaps in blind spots in care, especially for those in living in rural areas. And I would add that as a last piece with that it's a matter of infrastructure. It's a matter of literacy, education from health and data standpoints. And there's a variety of other things that are launching points from that we don't need to extend into right now, but I think are fully worthwhile to be unpacked as reasons for or drivers for those inequities or disparities in that space.
And I think out of this conversation, the goal, I think, from everybody is really to close that gap. And it's very important that, we look beyond our role, beyond our department or company's objective. And the goal should, first and foremost is how do we best serve the aging population. So I think it's great that we have this conversation and hopefully open up minds and ideas and innovation. So thank you. What do you think is the long-term impact of COVID on the elderly population?
So This is it's a glass half full versus glass half empty. Um, I I'd like to. I'm an optimistic person by nature, so I'll go with the glass half full. I think it's presented a number of opportunities. Um, I think it's demonstrated the capacity of disruption to happen for this community, and at the same time allow for a real time allow for a near real time demonstration of value, which I think is important when we think of creating a value proposition for industry or health systems in general to devote energies, personnel, economic resources into developing the platforms that are needed to help drive outcomes for this community. And I guess, a good example of that would be around telehealth. And that's been something that obviously has, in the past 20 years, this will be a little bit hyperbolic, but it's kind of languished, right? It developed, but it didn't have that disruptive catalyst to create the demand signal where it would become a integral part of our care delivery system. COVID has done that. COVID has allowed us to look at the human services and the healthcare delivery side to say, how do we serve aging populations where they are? How do we best do this in a way that respects their autonomy, their dignity, that creates the sense that they are engaged and have the self-efficacy within their care plans or within, the direction trajectory of their life, that they're doing it in a way that not only supports their presence in the community as a continuing to thrive individual, but also serves that value piece from the healthcare economy standpoint in terms of making it a mix that works for Medicare, for private insurers, for the health tech investors, for venture capital, all in a way that will be a sustainable footprint, right? Because the artificial nature of funding for the American Rescue Plan or these repeated COVID bills is that will, dry up. As important as the government can be in service of initial disruption, to find sustainability, I think it has to transition at some point back to the private sector. And I think that we're seeing that more and more.
Mm-hmm. Thank you. Thank you for your feedback.
Yeah.
Now, I would like to acknowledge Nyan McDonald. She has a question, and perhaps you can help answer. Can you talk about some of the resources that might be available for immigrant, non-English speaking elderly? There is a struggle in rural areas, as you mentioned. So are there accessible resources available?
So thank you so much for the question. I think that that's a critical consideration as we were discussing some of the subpopulations that might be falling through the cracks. And as you can imagine, I think a number of advisory notices have come out from the HHS Office of Civil Rights on this standpoint of what telehealth needs to provide, what providers need to include in their offerings to ensure that they're compliant with the regulations set forth by HHS and the Public Health Service Act or any of the standards regulations from ONC. And one of those is with limited English proficiency. So that means having interpreter services available for folks with difficulty hearing, hard of hearing, limited sight, or blind. There's requirements on that from those angles as well. It has not worked well by and large. One of the things I hear, and this is anecdotes because I don't have a good published data to pull from just yet, but that it has been an issue across Medicaid, Medicare, in some instances, and in the private sector. And partly it's because of the lack of resources. I think another part of this is that you're kind of building the plane as you're flying, right? It's that old colloquialism, but I think it's very true in this space that there is it's similar to what we just spoke of in terms of COVID being the great revealer. for populations that had problems with accessing care prior to the pandemic, it's become more so. So I think those populations I just mentioned are in that boat, and along with LGBT communities and others that found it difficult to access for a number of reasons, whether those were physical, whether they were stigma related, or others.
Very true. So as we progress, I know we touch on many points, but I think anything that's really, I guess, really important, maybe we can do a deeper dive. For instance, what solutions do you think are necessary to protect the elderly from COVID?
Ooh, that's so, and this is where I think taking a step back, right, and looking at the pandemic across the last 2+ years and assessing what the relative risk of certain interventions are is absolutely necessary, right? Because the initial data has, started to show, obviously vaccination, that is critical. The routine public health interventions of physical distancing, if possible. The mask wearing has been especially protective for aging populations. Even and this is where there's the issue as it relates to isolation versus loneliness, and getting to the risk assessment of how can we navigate that space well to ensure that it's not just mitigation of COVID risk, but ensuring that the rest of life remains intact. Because looking at the most recent values I've seen in terms of excess deaths attributed to COVID, it's as many deaths as are due to COVID itself in the United States. So problems of not seeking care for cardiac arrest, for heart attack, for stroke, for other chronic disease related issues, even preventive care services and preventive cancers, if we're not retaining the access to those pipelines, I believe we're going to do ourselves a disservice to that population and ultimately to ourselves, because we're not investing in an appropriate mix that values the entire spectrum of an individual's life. And it limits us to looking at the trees when we need to retain focus on the forest.
Hmm. Very true. So, what is your thought on how can we ensure that older adults receive the necessary care for any future pandemics, for example?
So the process of ensuring care or ensuring the appropriate framework is in place, I think is something that needs to be considered as a collective approach, right? You can focus, or various entities could focus on aging populations in isolation. But I think that the key is to ensure that there is recognition that pandemics need to be addressed as a community-based, at a community-based level. So by that, I mean, aging populations play a vital role where they live, where they work, where they play. And if that is not an active consideration in a community development plan or in a community preparedness and response plan that would include pandemics, I think that's one of the sure ways to set that population up for failure in the future. I think we've seen that, not necessarily limited to aging populations. I think all populations have found themselves in some way not adequately prepared for or suited to respond to what the last 2 years brought us. Obviously, for many of us, we were probably better suited because we were well versed with health IT, or we had frequent contact with telehealth already, or we knew how to navigate apps and other smart-enabled platforms to ensure we remained in good contact and had our preventive care on track. For those that respond or require, by mail, that require in person, that require a number of other means that use touch points to ensure care, I think that's where the problem lied. And I'm hopeful that that will change, at least at the federal level. There is a concerted effort to make sustainable, or at least have codified, what steps need to be taken next time. And with the audience that's online, I am absolutely certain they'll say, well, what happened in 2003? What happened in 2011? What happened in 2014? And I'm speaking of SARS, H1N1, Ebola. Every time one of these things happens, children and aging populations are going to be hit the hardest. But we did not take the time as a nation, as states, as communities, to build those considerations into our thought process in an intentional way. An ounce of prevention is never as attractive as a pound of cure, but I am hopeful that that will be the case this time.
Mm-hmm. Thank you so much. I'd like to acknowledge Len. He is asking about what effect, if any, have community-based health initiatives had on reducing disparities?
Oh, Len, great question. Thank you for chiming in. The idea that disparities could be addressed primarily from a top-down, federally driven initiatives, thoughts, ideas, programs is not realistic. It's not what the federal government's for, and I don't think anybody has any real illusions that that would be the case. So with that, I think my goal in that statement is to say community-based organizations, CBOs, have been hugely important in reducing disparities. When they are leveraged, when they are empowered, when they have the opportunity to serve as a true representative for those communities, and then use resources in a way that responds to identified gaps and opportunities, I think that's where much of the power comes in. The area where I've seen the most, I would say, dissonance between the theory and reality of that is in the way grant funding works from time to time. In that, I mean, if we go through a standard grant making process, you may not have grant writers within these CBOs. Again, they may not have private funding or existing funding from their usual operations to support these projects while waiting, 9-10 months for funding to come through from a grant that was written a year ago. So the construct that has been utilized in the past is not necessarily effective to empower the people that need to be the action officers in this. And that's me going back to some military time, just understanding who's going to be doing the work. Those should be the folks that are driving the bus with the funding. So I think that they are absolutely critical. I think that disruption is occurring that is allowing much of, our ability to characterize problems in a way that's meaningful to policymakers and decision makers. I think that there's a disruption coming to CBOs where they're able to curate and be good stewards of data in a way that they had not before. And I think that is leading to a more symmetric balance of not power, but I'll say symmetric representation in solving problems in a meaningful way.
Very complex matter, and thank you for your feedback on that. I'd like to acknowledge Rick, a previous guest on the show. So in many cases, older adults need assistance to access telehealth. Is money available to help older adults for this purpose?
So, Rick, that's an excellent Excellent question. And it's something that has continued to come up because, and this is another, I think, fabulous opportunity to bring up one of the issues that COVID has revealed, right? So telehealth can be a great good when it's equitably distributed, right? So, equal opportunity, not necessarily equal outcome. But if you don't have broadband access, if you don't have wireless, if you don't have even, like hardwire or fiber optics um, for other types of internet connectivity, it really it leaves you with limited options. And though we've seen audio only as an option for telehealth for these populations, it's not optimal, right? For some diagnoses, it may be, but if we already understand that there's no connectivity or degraded access as a baseline, it starts things off with an understanding that the lack of equity is a potential contributor to driving a widening disparate outcome. So in terms of what funding is available, there are a number of broad federal family initiatives that are increasing access in rural communities specifically. And not just federal, but state level, local level, private organizations have gotten involved in terms of providing funding to communities to allow for creative and novel approaches to bringing in, I guess, Band-Aid measures while broadband is being brought into communities. So the organization that is the lead for federal government on that is the FCC. And to a lesser extent, HHS is engaged, but we are engaged in lockstep in terms of, well, we see broadband is going into this community. What can we do to drive programmatic development or scale existing organizations in their approach to getting education to providers, to patients, to make sure that there's infrastructure in place on top of the actual broadband when it does come in.
Thank you. Thank you so much. These are definitely very difficult, complex questions, and I appreciate you answering them. There's definitely not a silver bullet solution to any of this, and I appreciate the audience asking. I would like to acknowledge Robert Bowman. I think he tagged Dwayne Clark from Ages Living, indicating that longevity is decreasing for about 40% of Americans most behind. Longevity, mortality, premature death, smoking, diabetes, mental illness, obesity, and so forth. And many more are 45 to 50% found in 2,621 countries, lowest in healthcare workforce with 40% of the U.S. population.
So I think what I'm reading from there is that's more of a statement, and I agree that for a variety of reasons that is the case, and I think you lay out quite a few of them there. The one that I might add, especially for populations from 55 to 69, is the increasing rate of overdose death in racial ethnic minorities, especially Black men. And this is related to that transition in the opioid epidemic, where we've seen an increase in fentanyl analogs and a decrease in prescription opioid use and even decrease in heroin use. So that is an increasing area of, I think, as we look at the share or the proportionate burden felt by emerging crises, it's another example where aging populations do suffer more on the extremes. But I appreciate that contribution. That was helpful.
Do you want to take on? I would like to acknowledge Len. Did I hear you say earlier that the healthcare needs to count on private sector for solutions? You talked about the grant process for seeking funds. How can the private sector become engaged in providing solutions?
Len, I appreciate that. Yeah. So I believe that that's a tried and true structure for government and private relationship. And part of what I base that on is the history of things like DARPA and ARPA-E, where you have had accelerated development in areas where disruption was not prioritized, either through lack of interest, lack of perceived value, or the desire to, serve as a barrier to keep disruption from happening because it's not in the incumbent's best interest to move forward. So the examples I think of are, the internet or GPS, those are the usual ones thrown around about DARPA. So what we saw was significant government investment, or even the Human Genome Project. So significant government interest. Toss it up front. Once it was developed, it started to create a value proposition, then, or a sustainable business model. Then, private sector is able to jump back in. VC is able to jump back in. I think the same thing is true for these types of solutions in the health tech area. And where I'd see this most appropriate for private sector becoming engaged is in what we call, and some of the listeners may be familiar with, going through the valley of death as a IT developer, or health tech developer or drug developer. It takes quite a bit to go from a struggling startup to make it through to regulatory pathways, or in this case, if it's a health tech device, could be a wearable, remote patient monitoring, to get through, the FDA considerations for regulatory device approval, then to get through reimbursement for with Medicare, Medicaid. So I think it's an interesting relationship where private could come in and serve as a shepherd to bring folks through a little bit more fully through that valley of death. The issue is that many times, if you get through their initial VC money and they require a little plus up and it doesn't come, and then good ideas die on the vine, or they can get, bought up and then not be, pushed through to the people that actually need them. So I think that that's one of the touch points. The other, I think, is probably, working with the private sector, working with private insurers, because they have a bit more flexibility in how they approach things with regards to developing. And the example could be like a Medicare Advantage contracting organization, where they can develop their approach to treating their population, including, excluding, and growing, maturing based on their population's needs. And I think that's where at times you do get that nice marriage of private to private that can ultimately inform back to government, because Medicare Advantage obviously informs back to CMS.
Do you want to read Robert's further comment?
Perfect. Yeah. I'm reading through your second comment here, Robert.
Can you see it entirely, or do you need me to scroll?
No, I'm scrolling.
Oh, okay, good. Feel free to read out loud so that others can hear it.
So let me read out. So Robert, I'll start from your longer comment here. So America is unique that we have worse healthcare designs as we get older, poor, disabled, mentally ill, or need more healthcare. As we get older and therefore poorer and sicker, we can no longer afford the high cost of housing and living in high concentration counties. People, health workforce, social supports. Therefore, we must move to counties lower in cost of living and housing. People move in with family or others, or must go to the 2,621 counties lowest in healthcare workforce that are lower in cost in social supports. Internal growth in these counties is high, and the immigration is high. Also, retention is high. These are factors in the most rapid most rapid growth of these counties dating back 60 years. By 2060, this 40% in 2010 should be 50% or a majority of the U.S. population, even more behind as the healthcare designs continue to pay less and close and compromise their hospitals and practices. If you understand the majority of the population most behind and what remains of their healthcare, you will question micromanagement, innovation, and other costly and meaningless attempts to improve outcomes dating back decades. You'll understand that only 1965 to 78 did they get any real increases in funding. You'll understand that reforms since the 80s are all a tie for the last place as far as helping these counties. That covered a lot of ground. And I thank you for those comments, Robert. I love having these kind of these philosophical discussions around why it is what we're doing. Is it meaningless? Is there a better way? And then looking at what the historical kind of comparator is. And I agree that, there is a reason for where we are today. And the here I'm speaking to is the observation that though poverty has decreased markedly for aging populations since Social Security came into existence, it has certainly leveled off per Robert's observations in terms of diminishing return on what it is we're doing to improve quality towards aging populations and entering the end of life. So from that standpoint, I think it, okay, there's another one from Robert, but I'll finish this thought briefly. It's clear to me that the US and other countries, other OECD countries, were not apples to apples, right? There was a decision made many decades ago that we would follow the private insurer pathway. We would privatize medicine. We would have a market-based system and not go the path of universal care, at least we have it, but we don't, right? So I think it's so difficult to compare and say we should be doing X, Y, Z. I do believe strongly that less is more earlier in life. And I do think we've gotten away from that in medicine. We've gotten away from that in public health. And I think it's done a disservice to how patients, how individuals view the power they have over their own lives. Because there was a time when there wasn't a pill for everything. There wasn't a solution from the doctor, right? Or from healthcare. And there was an inflection point when, the per capita number of pills that we take went sky high. I mean, multiplied by thousands in the space of a decade. And I think that also corresponds it was an early predictor of that range of the 60s to 70s that Robert mentioned. But I think that there are always simple solutions. And while I agree that less should always be more, there is a place for ensuring the advancements that do take place are done so in a way that ensure equitable access for folks that need it most.
Mm-hmm. Great. Thank you so much. I'd like to acknowledge Terry's comment. Terry Cruz. He indicates that passive remote patient monitoring with local processing of data removes the need for high bandwidth. Only events are sent to monitoring entities. There has been too much focus on the modern model bandwidth. Do you see RPM becoming the norm?
Oh, Terry, that's thank you for reminding me of that. It reminds me of a model, and I can't remember the state offhand. There's a great vendor that is essentially providing RPM for a number of indices where it allows patients to drive by. If they're in a rural community, they can just drive by a cell tower, it'll ping and then be sent off to the cloud, and then the provider can access it. So it doesn't require them to have broadband in the home, but allows them to upload that via just driving in proximity of a cell tower when they go to the market or go for drive somewhere. So I do think that RPM, as it becomes a more mature tool that can be utilized in provider and patient interactions and workflow in a meaningful way, it will become a good tool, because the 90% of life that occurs outside the clinic walls, and not when we're getting our blood pressure and heart rate taken by a clinician or staff in care setting, is it's artificial, right? It's always best to have that capture of people where they are and doing what the rest of life contains. So I appreciate that. Thank you, Terry.
There's another one that I don't know if you can see the name, but I cannot.
No, it just says LinkedIn user.
Right. He's indicating that, are we seeing more fluid adoption of technology where the aging population will become more self-serving? In other words, LOT in the homes, wearables, and so forth.
Yeah. So I think that is certainly going to be the case. One of the interesting outgrowths in a number of Medicare Advantage organizations that are attempting to drive up the utilization of health IT for their aging populations has been, more standardization of RPM as a component of their integrated care delivery. So I think it certainly will be. And as much as, and you can imagine that as these catch on, and by catch on, it will be improved outcomes from the standpoint of, optimization of chronic disease management and quality of life, increased satisfaction with interaction with providers. And I think and I mentioned self-efficacy, but I think it's so important to feel like you are in the driver's seat, to feel like you have ownership, that you are you're in control of your life. You're not going to the doctor to ask for permission to live a certain way. Patients, individuals are, and I said this in a class last night, they know much more about clinicians than there's no better teacher about you than you. And granted, there are different ways to convey that experience, to convey what you know, but by and large, I think, when I come to learning from someone that has lived experience in an area, I turn my ear to them before I turn it to an expert. And I have to say that knowing that I, am in the same boat being a provider. I don't expect folks to listen to me before they talk to their father, their friend, there's somebody who's been through a similar experience, right? So I think that self-efficacy and trust are so important.
Mm-hmm. As you're talking about that, perhaps this is in parallel. I often think that taking ownership, responsibility of your health, it's beyond that one visit a year inside a doctor's office. Okay, that's just a short window of time. But I think throughout life, day to day, you got to take ownership. Because we don't see health as, we shouldn't see health as the objective to achieve. It's really day-to-day goals that we have to take care of ourselves, right?
Yeah, I feel that, if we look at health as the end goal, we'll get exhausted. The goal is contentment in life, right? Being okay with who you are, where you're at, your surroundings, your relationships, and your choices. And stemming from those healthy choices, I think, stem from that positive place where you're in a balanced, resilient place. And that does not come from ceding your autonomy to, the medical providers or to anyone else in your life, right? I mean, there are sources where you can reclaim and become that, and take steps towards being that version of the resilient self. And I firmly believe that it can start and should, especially for populations that have historically been on the short side of the power dynamic with clinicians, it should be incorporated in those interactions.
Great points. Now, I'd like to acknowledge, I think the last comment that we read is actually from Nick Patel from
Right.
ThriveWell Tech. Thank you so much for your comment. Now, I want to make note that we have about 10 minutes
Okay.
remaining, and I have about 8 questions for you. However, I know that we can continue in future conversations. I think it's great that we acknowledge and reply to our guests. How do you want to do this, Dr. Lee? Should we continue with the questions or go with the guest
You know,
comments?
what is your, I don't want to buck the house rules. Do you have a usual convention that you follow? I'm more than happy to, I know we spoke about having another session, so we can always plan to add those questions for a next session, depending, however you'd like to proceed.
Sure, sure. Well, let's continue. I have a couple other questions, and we
Sure.
can continue here. So let's see. Every time I try to reflect on these questions onto you, I realize how complex they are, but it's necessary to uncover them and talk about it openly with the audience and ourselves. So what solutions do you think should be put into place to ensure that elderly are able to live healthy and productive lives? I know we touched on throughout the conversations, but do you have any top tips to make sure that happens, to allow that to happen?
Well, I think you've heard me go on about self-efficacy, right? So I
Mhm.
will always be a proponent of that. Resilience, connection with family, with friends, with meaning in life, right? I think I'm getting to the age myself where I'm starting to see where the successes are, where folks are continuing to thrive as they enter into the next phases, stages of life. And there's something special of being able to turn a page on one chapter and move boldly into a next phase without uncertainty. So much goes into that. But I think as much that folks can remain tied to who they are, and I know this sounds a little abstract, but it's so important to maintain that sense of identity over the lifespan, right? To not become awash in the requirements of the day to day, but to be focused on what the end goal is, and that's the contentment with who you are. So the other things fall in around that, right? So we talked about self-efficacy, community, relationships, valuing yourself, staying plugged into care as you can, whatever mechanism that takes. If you're a veteran, don't be too stubborn to go to the VA. If you have opportunities for Medicaid, Medicare, dual eligible, take advantage. If there are lower cost options that allow you to be seen at a community clinic, at a public health clinic, these are things I think that we should still take advantage of. And I say that, having done, the public health clinics growing up, or having to go, being part of military medicine for so long, and now being a VA patient, it pays to stay engaged, but to do it in a way that you remain cognizant of what your ultimate goal is. And it's not to make doctors happy. It's not to be shamed into doing better, but it's to maintain that identity, the contentment, and to drive towards health in a way that is just a byproduct of your life rather than the sole, driving factor of your life.
hmm Thank you. Thank you so
Yeah.
much. So let's talk about nursing homes. So what's being done to prevent, reduce COVID-like pandemics in nursing homes or other care
Yeah.
facilities in
Yeah.
the future?
So that's been so nursing homes have been a focus at the federal and state level. Y'all recall that there were quite a few missteps and controversies early on in the pandemic with poor training, lack of empathy, poor communication with family members, inability to test, inability to really provide for the routine needs and care due to um, real perceived, overblown concerns, or just lack of established protocols that would otherwise have ensured appropriate care that it respected the values, the time left for some of these patients, and help them retain connection, right? And I'll cite one program I think that has been really, beneficial and leverages teleservices, but not telemedicine aspect. It's Project Echo in a partnership with ARC, which is the Agency for Health Research and Quality. Project Echo is a telementoring platform whereby you have different types of clinicians that can be sourced into a video setting to receive education, continuing education on a topic. And there was a large initiative through ARC that's still ongoing, I believe. I can't recall the current state and how large it is, but to increase education for nursing home staff, providers, and has resulted in improved outcomes, improved quality of life, improved satisfaction, and decreasing transmission and poor outcomes and morbidity and mortality from COVID. It's a small thing when you think about it. You think, well, why wasn't this already being done? It's, you do continuing education. This was just a novel means to apply Project Echo in a setting that had not been done previously. So I think it's served as a model to show, okay, this is something that is not costly, but can have big impact across the country when we administer it in the correct way. So that's one thing I just highlight as a way to keep people healthy when they're in that setting.
Mm-hmm. Great. Thank you so much. We have about 2 or 3 minutes left before this event likely to kind of cut us off here. It's happened in the past. Even though I leave the end time open, but it likes to cut us off after an hour. So I'd like to wrap it up to let you know that Dr. Leith and I will have continued conversations to finish this, and then there's other topics to add on. So please look forward to the future. And remember, with an aging population, closing the care gap for all Americans is critical. So we must ensure that no senior falls through the cracks and loses health due to lack of resources. And to get started or to continue to do what you're doing, here are just a few things that you can do even more to ensure that seniors have access to quality care, regardless of their location or socioeconomic status. Well, urge lawmakers to pass legislation to protect the rights of seniors and their families. Urge politicians to pass legislation to support senior care. Lobby for regulation of unlicensed assisted living facilities. Raise awareness about the benefits of aging in place. Support local charities that provide free or low-cost senior care services. Lobby for legislation that makes quality senior care more affordable and accessible. Support family caregivers by providing training and resources. Encourage employers to allow employees flexible work arrangements to care for their elderly relatives. Promote programs to provide respite care for family caregivers. Fund research on the best ways to provide quality care for seniors. Promote public-private partnership to increase the availability of senior housing. And of course, help seniors in your community access resources that they need. Start or join a group that focus on elder care issues. Volunteer your time at a local nursing home or assisted living facility. Donate money to organizations that provide support for seniors. Remember, speak out against ageism. And finally, don't forget to vote. Policies affecting seniors are made every day, so it's important that your voice is heard at the polls. And we hope the ideas, the conversations, and the leadership from Dr. Leith today has given you some starting point, how we all can continue to do and do better. So let's work together and close the gap in care for all Americans. So please tune in next week. There will be 2 topics. We will discuss American dementia brain health in an unhealthy society, humanizing dementia care for the elderly. Rather than focusing on the shortcomings, affirm and respond to your loved one's needs, fears, and desires. We'll also be discussing about venture capitalists' review on how they decide which senior care products to invest in. Remember to subscribe to our YouTube channel, Aging Media Show, and leave a review on iTunes podcast, Boomer Living. We thank you so much, and I thank you so much, Dr. Leith and the audience, for joining in this conversation.